Okay. Hello everyone, welcome to Auricle Exam Mastery Classes. So today's topics will be covering yolk sac, implantation and development of placenta. I'm Dr. Divya, life class educator for Auricle. So before we go in for today's classes, we'll understand a little bit about Auricle. So these exam mastery classes we have started from last month, and this month again we continue for a duration of 30 days. So here we are doing a rapid revision of all important questions, quick revision of volatile facts. Then we also cover high yielding topics as well as most expected questions in the subjects. Here, these classes are beneficial for everyone, for all the university exams of all the states, as well as it is also helpful for NEET, PG and FMG exams. The core features of Auricle include live classes, recorded classes, which you can access anytime, anywhere, as well as we also give you the CBME-based question and answer notebook, which also contains MCQs, which are from the beginner level to the expert level. So they're all standard multiple choice questions, which are asked in various entrance exams as well as in the university exams. First MBBS. So you can use the code Dr.Divya 20 for the discount on subscription. We have 3 subscription plans, the basic, standard, and the mentorship. Basic is for 3 months, standard 6 months, and mentorship is a wholesome program for about 12 months. So this we offer you at a special rate of 50,000. And here, in addition to the services offered in the other 2 subscription plans, we also give you one-to-one personalized guidance as well as notes. You can also book a slot for personalized counseling session on Auricle app. So we'll begin with today's classes. So objectives of today's class are, we are going to study about the formation of the yolk sac, its derivatives and feed, the implantation, types and abnormal sites of implantation, and development of the placenta. So first coming to the yolk sac formation. So usually when we talk about the yolk sac, so first is the definition. So what do we mean by yolk sac? Okay, so first you need to write the definition of yolk sac. Okay, so what do we mean by yolk sac? Here the definition. So what is yolk sac? Yolk sac is an endodermal sac. Okay, yolk sac is an endodermal sac which lies. So here, if you actually think about it, this will be the endoderm, and here endoderm, we have seen it in the previous classes, how the cavities are formed. So the yolk sac is a endodermal sac which lies ventral to the embryonic disc, that is anterior to the embryonic disc. So this yolk sac as such, in humans, it is a vestigial structure, okay? But then it has certain functions here, okay, during the period of development. Now, the yolk sac develops from which one? From the cavity of the, so it develops from the cavity of the, which one? The blastocyst, okay? So the blastocyst cavity, where from the endoderm, the cells migrate, they form the Hughes membrane and encloses a cavity, which we call it as the yolk sac. So during the development, the yolk sac follows 3 stages, okay? The primary, the secondary, and the tertiary. So the primary is, yolk sac is the cavity of the blastocyst will be converted into the primary yolk sac when it is lined by a flattened cells, which are derived from the endoderm, okay? So if you see 2 layers, now this is the ectoderm, this is the endoderm, okay? And outside is the cavity here. So from this endoderm, what happens? Cells will migrate all around. Okay, they form what we call it as the Hughes membrane, and this cavity becomes the yolk sac. This is the primary. So these flattened cells, we call it as the Hughes membrane. So this primary yolk sac, it is formed. Okay, so the primary yolk sac is formed by the end of second week. So this is formed by the end of second week. We see the primary yolk sac. Then we have the secondary yolk sac. So secondary yolk sac. Okay, so secondary yolk sac, what happens here? So secondary yolk sac, here between this, now here, this is the cytotrophoblast, okay, and this is the Husser's membrane. So between that, what happens here, the extra embryonic mesoderm will appear. Okay, so we have the appearance of extra embryonic mesoderm. So with the appearance of this extra embryonic mesoderm, and then after that, there will be formation of the coelom, the yolk sac is reduced. Okay, it is called as this one, that is the secondary yolk sac. So this is the secondary yolk sac. Okay, secondary yolk sac. And the cells lining the yolk sac now, they become cuboidal. Earlier it was flattened, now they become cuboidal. Then we have the tertiary yolk sac. Okay, this is the tertiary yolk sac. So tertiary yolk sac, we otherwise call it as the definitive yolk sac. So this is the remnant of the secondary yolk sac. Now what happens with the further folding of the embryo, no? The most of the yolk sac is taken within. Okay, so when the embryo folds here, this is the folding of the embryo like this when it folds. So most of the yolk sac will be taken up inside, which forms the primitive gut. Okay, so primitive gut will form the primitive gut. So whatever the portion of the yolk sac is left behind, okay, this is known as the definitive yolk sac. So this yolk sac or the definitive or the tertiary yolk sac will be communicating with the midgut here, if you see, through this vitellointestinal duct. Okay, so this is the vitellointestinal duct. So these are the three stages, okay, the primary, the secondary, and the tertiary tertiary stage, primary, secondary, and the tertiary stage of the yolk sac. So definition and what is the development. So next, what is the function of the yolk sac? Okay, so function of the yolk sac, one is it helps in the hemopoiesis. So till the formation of the liver happens, okay, so yolk sac is the site which is responsible for hemopoiesis. Okay, and this will continue up to the 6th week. So by 6th week, what happens? The liver takes up the function. Then it is responsible for the formation of the primitive gut. Okay, so the portion which is taken up inside, it forms so you can see this portion is taken inside and this forms the primitive gut. Then from the walls of this yolk sac, okay, from the wall of the yolk sac, the primordial germ cells, okay, so primordial germ cells are formed from the wall of the yolk sac. Then from this wall, they will migrate, okay, where the gonads are developing in the coelom posteriorly, okay. So to that it will migrate later on, but the primordial germ cells, they are formed in the walls of the yolk sac, okay. Then it also forms a diverticulum, which we call it as the allantois. So it is responsible for the formation of this diverticulum called as the allantois. Okay, so this is very essential because allantois take part in the formation of the bladder, apex of the bladder. So here you can see this is the small part of the diverticulum. Okay, this is the allantois. So what is this allantois? Allantois separately can be asked as a 3-mark question. So allantois is a small diverticulum which arises from the caudal end of this yolk sac. Okay, from the caudal part of the yolk sac. So this appears, so it is a diverticulum, and this will usually appear by the end of 3rd week. Okay, 3rd week. So this later on it develops, okay, and it forms a part of the connecting stalk of the embryo, developing embryo. Now, why this allantois is responsive? What is its importance? Okay, allantois after the embryo folds, it forms a part of the hindgut. Okay, it forms a part. So now you can see after the folding of the embryo, forms a part of the hindgut. This is the hindgut portion. So this allantois, it is vascularized by allantoic vessels. okay, which later they are called as umbilical arteries and vein. Okay, umbilical arteries and vein, the allantoic vessels are called. So, and it later on it forms the that is, it contributes to the apex of the bladder, and later on it is represented as the median umbilical ligament in the adults. Okay, so it forms that urachus which contributes to the development of the apex of the bladder. Yeah. So that is the importance of allantois. So coming to the applied aspects. Okay, so applied aspects for yolk sac, you need to write about the Meckel's diverticulum. Okay, so what is this diverticulum, Meckel's diverticulum? Now, if you see this yolk sac here, the stalk of this thing, the yolk sac, that is the tertiary yolk sac, is connected to the midgut by a vitello-intestinal duct. Okay, so usually what happens, this gets obliterated and it disappears. But sometimes the portion of it, okay, it will remain. Okay, the proximal part here near the midgut, it remains, okay, and it forms the Meckel's diverticulum. So that is, you have to write. So you can see Meckel's. So Meckel's diverticulum sometimes forms a part that is commonest cause for obstruction, okay, in the intestine, where the coil of the intestine will wind around that Meckel's diverticulum, and it can cause symptoms. So usually we see it in the antemesenteric border of the intestine, which is about okay, so it is seen in about 2%. It follows the rule of 2. That is, it's seen in about 2% of the people. It is about 2 inches in length and lies about 2 feet from the ileocecal junction. That is its common position. Okay, so that is Meckel's diverticulum. Next, other thing is vitellointestinal anomalies of that vitellointestinal duct. What we can see is sometimes, since it remains like this is the midgut. So here, this portion, if it remains patent here, what happens? It forms, this is the distal part, it remains patent, it forms a Meckel's diverticulum. But if the proximal part towards this is the body wall, okay, if it remains patent, this is the umbilical opening now, it will form the sinus, that is known as the sinus of vitellointestinal duct. Sometimes the entire vitellointestinal duct will remain patent, connecting the umbilicus to the midgut. So that forms a fistula. Now here, this is the fistula. Okay. And so we can see the fecal material coming out from this fistula. Sometimes both the proximal and the distal end both will be obliterated, but in the center it will remain patent, and that we call it as the cyst, vitelline cyst. So these are the abnormalities of the vitellointestinal duct. Okay, so allantois, so you can see here, this is the hindgut, this is the allantoic part, okay, where it will contribute to the formation of the bladder. Okay, so after that it gets obliterated and forms the median umbilical ligament. But if it doesn't, it forms the fistula. Okay, it can form here, same thing like how vitellointestinal duct, same thing here. But vitellointestinal duct will be connecting it to the gut, whereas here this will be connected to the apex of the bladder. So this is the urachal fistula, okay, where the entire allantois remains patent. Here what happens, the proximal portion remains patent, the distal portion would have formed the ligament. Okay, so that will form the sinus. If both the proximal and distal portion, here it obliterates and only the center, urachal cyst, just similar to vitellointestinal duct. So when we write about yolk sac, so we write what is the definition of yolk sac. So it is an endodermal sac, okay, and which lies ventral to the developing embryo, embryonic disc, isn't it? So when does it develop? So it is developed from what it is developed? It is developed from the cavity of the blastocyst. So we have 3 types during the process of development. It follows 3 stages. So that is these types, we can call it as the stages. Okay, so once we write the definition, we go for the stages. stages of development. So that is the primary, okay, which is formed by second week. Then we have the secondary. Okay, so primary is the initial, where the blastocyst cavity is lined by the cells from the endoderm, flattened cells from the endoderm, which we call it as the Hughes membrane, and enclosing the cavity, which we call it as the yolk sac, primary yolk sac. The secondary is with the formation of the extraembryonic mesoderm and the extraembryonic coelom. The primary yolk sac is converted into secondary. And the tertiary yolk sac is when most of the yolk sac is taken within the embryo, okay, after its folding, the remaining portion, we call it as the tertiary. And this tertiary yolk sac or the definitive yolk sac is connected to the gut, which is taken in by the vitelo-intestinal duct. So, Fate, what happens? Fate, so usually this yolk sac, before fate, we write about the function. So after function will be the fate. So function, what happens here? What does it do? It is the site of erythropoiesis. Okay, that is hemopoiesis up to the 6th week. Okay, by which time the liver will take up the function. So till then, it is the site of hemopoiesis or erythropoiesis. Second thing is it forms the primitive gut. Third, from these walls, the primordial germ cells are formed, which will then migrate to the developing gonad. Okay, so those things. So you will write about that. Okay. And it will be providing nutrition in the early stages. Basically, in compared to the animals where the yolk sac, like in the egg and all, no, we have more yolk which will be contributing to the development of the embryo. Here we do not have much. Okay, it doesn't contribute as such to the nutrition part, but these things are its form. So other thing is it also forms the allantois. Okay, so you need to write about. So fate is basically it will be reduced. Okay, it will gradually with the formation of the gut, the yolk sac disappears. Okay, and the connecting duct also gets obliterated. After it gets obliterated, the yolk sac will disappear. So congenital anomalies, we basically talk about Meckel's diverticulum. That is about the remnant of the vitelo-intestinal duct. Then also we talk about the abnormalities of vitelo-intestinal duct. That is which one? We talk about the sinus, the fistula, and the cyst. Next is implantation. Okay, so what do we mean by implantation? So first is always the definition. So what is implantation? Implantation is a process by which the blastocyst, okay, so this is the blastocyst here. So the blastocyst is embedded within the uterine wall. Okay, within the uterine wall means within the layer, which layer of the uterine wall? That is the endometrium. Okay, where it is embedded within the endometrium of the uterine wall and it is fixed there. Okay, embedded and fixed within the wall of the uterine wall. So this is known as the implantation. So during the time of implantation, now this embryo is in the form of the blastocyst. Later on, the cells will be undergoing different changes, isn't it? The inner cells and the outer cells, forming the inner cell mass and outer cell mass. So here what happens now? How does this process of implantation takes place now? See, the implant initially what happens is this blastocyst will be covered by a layer of that is the zona pellucida will be covering it. Why now zona pellucida will be covering the blastocyst till the time of implantation? Because the zona pellucida, it prevents ectopic pregnancy, embedding of this cyst. Normally this blastocyst, it has to implant in the upper segment of the posterior wall of the posterior uterine wall. Okay, or the posterior segment of the uterus. So till it gets implanted in that site, okay, it will be traveling through the fallopian tube and coming to the uterus, right? So it should not get implanted in any other abnormal places. So that is why the zona pellucida will be present. But once it reaches the uterine wall, there what happens? The zona pellucida will disappear. Okay. So after the zona pellucida disappears, this blastocyst enlarges. Okay, the blastocyst will enlarge, and the first layer what we see outside will be the, after the disappearance, will be the trophoblast. So the trophoblast now can get attached to the endometrium. Okay, so these trophoblast cells will cause eroding of the endometrial epithelium here. Okay, the epithelium gets eroded here. Okay, and then the blastocyst is taken inside. So here, once it is, as it is been taken inside, what happens? These trophoblast cells will divide. Okay, it undergoes mitotic division and forms new layer of cells, which we call it as the syncytial trophoblast. So the syncytial trophoblast will cause further invasion of this endometrium. Okay, so it further invades the endometrium with the help of the proteolytic enzymes secreted. And this blastocyst will get deeper into the endometrium until it completely lies within the endometrium. So this is called known as the interstitial implantation. So in humans, the type of implantation which takes place is interstitial. Okay, so first when you write about implantation, we will write the definition. Okay, and next will be the type of implantation, which is the interstitial implantation. Next is time of implantation. When is the time of, when does implantation takes place? It takes place 5th or 6th day after fertilization. Sorry, 6th or 7th day, around 6th or 7th day, it takes place. Okay, so the implantation usually takes place. Sixth day after fertilization. Okay. 6th to 7th day, that is by the end of the first week, the implantation occurs. So that is the time of implantation. Okay, next you write about site of implantation. So where is the site of implantation? So site of implantation normally is the upper segment of posterior wall of the uterus. Okay, so posterior wall is the normal site. Okay, posterior wall of uterus. So even if it is in the anterior wall, it is also considered as normal anterior wall also, but it should be in the upper segment. Okay, so that is the site. So first we will write what is the definition. So definition, implantation is it gets implanted within the that is the process of the process by which a blastocyst is embedded and fixed within the endometrium of the uterus is known as implantation. The type of implantation is interstitial. Time is takes place by 6th or 7th day after fertilization, and site is at the upper segment of posterior wall of the uterus or the anterior. So normally it is there. Okay. A site of normal implantation. So other types, other than interstitial, we have other two types of implantation, which we call it as eccentric implantation and central implantation. Eccentric implantation, what happens is the blastocyst gets embedded within the crypts of the uterine wall. Okay, uterine crypts we say. So between that, it gets embedded. Usually it is in the rats it happens. And central implantation is it just gets attached in the cavity. Okay, within the cavity. So that happens in case of cows. So cows, we see central implantation, and eccentric, we see it in the rats, okay, where it is embedded within the uterine crypts. Then coming to abnormal sites. So this is very important, abnormal sites of implantation. So where are the abnormal sites of implantation? So it can be uterine or extrauterine. Okay, so in the uterine, okay, uterine, it can take place in the fallopian tube. Okay, fallopian tube is a part of the uterus, right? So it can take in the fallopian tube or in the infundibulum, that is in the ampulla or the infundibulum, and in the interstitial part. Okay, so here, now if it takes place here, This is the infundibulum. Here it is tubular amphilar and isthmus. Okay. So in this part, it can get implanted. Okay. And then it can also get implanted in the lower part. That is the cervical part. Okay. Cervix, near the cervix. So that is the intrauterine sites, abnormal sites. Whereas extrauterine, outside the uterus, where it can get implanted. Okay. So one is in the abdominal cavity. That is usually it gets embedded within the peritoneal lining. Okay, of the recto-uterine pouch. That is between the uterus and the rectum. Okay, in the peritoneal lining, it can get implanted. Okay, and sometimes in the mesentery, it can get implanted. In the ovary, which we call it as ovarian implantation, it can happen in the ovary also. Okay, so those are the abnormal sites of implantation. So that is about implantation. We write about the definition. Then we write about the type. Okay, so first definition, what is implantation? The type. If it is a 5 marks question, we describe the process of implantation. Okay, so before we go in for process, we will write the time and site of implantation, site. Then we go to the process of implantation, that zona pellucida disappears, then the trophoblast gets attached to the epithelial lining of the uterine endometrium. Okay, and then it sticks to that. The cells, they erode that epithelium by the proteolytic enzymes, the trophoblast multiple. Okay, it divides by mitosis and forms the layer, syncytial trophoblast, and that will help in further embedding of the blastocyst within the endometrial cavity. So once the entire blastocyst is taken with, okay, so the cells there, no, at the site, they form the uterine plug and it will heal up. Okay, the epithelial cells will grow back there and the entire blastocyst is taken within. So that is known as the interstitial implantation. And then you write about the abnormal sites of implantation, okay, which can be uterine or extrauterine. Okay, uterine, basically, we talk about the fallopian tube. Okay, and this is known as this here in abdominal, that is in the peritoneum, pouch of Douglas, or in the mesentery. And then we have, sorry, in uterine, we had cervical also. Then we have it in the ovaries. Okay, so they are the abnormal sites of implantation. So next we come to the placenta. Okay, so what do we mean by placenta? So placenta, what do we call, what is placenta now? Okay, so placenta is basically the organ, okay, which will help in, what does it help in? It helps in the, it has many functions, isn't it? It is the main site of nutrition as well as it helps in exchange of gases. So basically provides the nutritional support, the gases it provides, okay, to the developing embryo. So to understand the placenta, now this placenta we need to know develops from two sources. One is the fetal part, another one is the maternal part. So when we talk about fetal part, okay, the fetal part is formed from the chorion frondosum, whereas the maternal part is formed from the decidua basalis. Okay, so the fetal part from the chorion frondosum and maternal part from decidua basalis. So we should understand what is this chorion frondosum and decidua basalis. So first is understanding the decidua. Okay, so with the disappearance of zona pellucida, the blastocyst, okay, when it is embedding within the endometrium, it initiates a decidual reaction within the endometrium. And now this endometrium, we don't call it as the decidua. Now endometrium, we know it has 3 layers, isn't it? We have the functional layer, we have the stratum functional layer, then we have the vascular layer, and we have the basal layer, vascular layer, correct? So here the functional layer now, it undergoes the change with the embedding of the blastocyst. And this layer now we call it as the decidua. Okay, so that is known as the decidual reaction. So usually, excuse me, so at the time of implantation, this endometrium will be in the secretory phase. So as this implantation is occurring, okay, so implantation, when we saw here previous slide, okay, so here what happens, these syncytial trophoblast cells, they will secrete one hormone, that is the chorionic gonadotropin, beta HCG, what is written there, that is the human chorionic gonadotropin hormone. Okay, so this hormone will intensify the changes. Okay, it will increase the changes within the developing. Now, this is the syncytial trophoblast here. So it will initiate the changes within this functional layer. Okay, which one? The beta HCG, it's a thing which is secreted by the syncytial trophoblast. So what changes it will have? What changes will happen here now? The stroma. Okay, so the stromal cells. Okay, the stromal cells will. That is stroma of which one? The endometrium. Now the stromal cells will increase. Okay, increase in size. So they enlarge. Second thing is they become vacuolated. Okay, vacuolated and are filled with, okay, and get filled with, and the vacuoles get filled with glycogen and lipid. Okay, glycogen and lipid. So this we call it as the decidual reaction. Okay, so decidual reaction basically initiated with the implantation. Okay, so the syncytial trophoblast will secrete the beta HCG, and this will cause this decidual reaction where the stromal cells will increase in size, and these cells will get vacuolated and get filled with glycogen and lipid. So now we call this endometrium now as the decidua. So this decidua, we now divided decidua, we divided in 3 layers now: decidua basalis, decidua capsularis, and decidua parietalis. So what are those 3 things? Decidua capsularis, decidua parietalis, and decidua basalis. So this decidua basalis is that part of the decidua which lies deep to the embryo, okay, where the blastocyst is developing. So this is decidua basalis. So it will be towards the embryonic pole. So this is the decidua basalis which contributes to the formation of placenta. Now the remaining part of the decidua around the blastocyst, we call it as the decidua capsularis. Okay, so this is the decidua capsularis all around it. So it is the part of the decidua which forms a capsule around the embryo. Okay, and this will be separating it from the uterine. So this is the uterine cavity. So this one separates the embryo from the uterine cavity. Whereas the remaining, next in all the other parts of the endometrium, okay, so where the other sides other than where the implantation has occurred. So in those part, this decidual change which has occurred, we call it as the decidua parietalis. Okay, so rest of the decidua, that will be called as decidua parietalis. That is, as the parietum is outside. So the rest of the outside endometrium, we call it as the decidua parietalis. Okay. So this is the decidual reaction. Decidua, so these 3 parts: decidua basalis, decidua parietalis, and decidua capsularis. So this is the formation of the maternal part of the placenta. Okay, the decidua basalis is the maternal part. Now what happens in the fetus now? So fetus now, the contributing structure is the chorion frondosum. So we have to understand what is this chorion frondosum. Okay. So in the previous class, we learned that what do we mean by chorion? So chorion was the extraembryonic, that is the somatopluric extraembryonic mesoderm, as well as the cytotrophoblast cell. Together we call it as the chorion. Okay. Now this chorion, that is first the trophoblast cells. So from the chorion, what happens is the cells will project. Okay, they form the villi. And these villi will undergo different stages of development. Okay, so initially they will be formed all around the developing embryo. Okay, so we can see it all around the developing embryo. But the development progresses more rapidly towards the embryonic pole. This is the abembryonic pole. Okay, so this portion, which is towards the embryonic pole, this we call it as the chorion frondosum. Whereas the remaining, okay, this chorion, which have formed the villi, towards the abembryonic, that is towards the decidua capsularis part, we call it as the chorion levae. They gradually disappear because here there is no embryo. But here there is embryo, so here they are developing very rapidly here. Okay, so that is chorion frondosum and chorion levae. So chorion frondosum contributes to the formation of the placenta. Okay, so you can see here. So this is the initial stage they are developing, but later on only towards the decidua basalis, the chorion frondosum part will develop well. Okay. Okay, so how they develop? Now I told you, so this is the somatopleuric layer. This is the cytotrophoblast layer, and outside syncytial trophoblast is there. Right, so now towards one pole, that is the embryonic pole, here it will be progressing. So initially, in the syncytial trophoblast now, what happens is, there is formation of vacuoles, okay, spaces will, as the cells are progressing, the cells will separate, they form what we call it as spaces or lacunae. Okay, so these are the lacunar spaces. So in between these lacunar spaces, the chorion, it will form the villi. Okay, the chorionic villi will be formed. So these spaces are now called as the intervillus because they will be lying between the villus. Villus is developing in this space, in this part, between the two lacunae. So these spaces are known as intervillus spaces. Okay, so first stage what happens is towards the embryonic pole now. Here only the cytotrophoblast will project, okay, between the intervillus spaces. So this we call it as the primary villi. Okay, so the first stage is the formation of the primary villi. In the exam, you can just show this diagram and explain. Or you can also show this also. This is also right. So primary villus. Okay, so the villi will project. Then what happens in the second stage now? Along with this cytotrophoblast, a core of the extraembryonic mesoderm will also project. Okay, so this we call it as the secondary villi or secondary villus. Villus is single, villi is plural form. Then tertiary villus here, what happens? The cytotrophoblast, the extraembryonic mesoderm, that is the somatopleuric layer, okay, plus the fetal capillaries. Now, these fetal capillaries would be formed by the, which one? The capillaries derived from the allantoic vessels. Okay, so the allantoic vessels will form the fetal capillaries, nothing but the capillaries derived from the umbilical artery and vein. Okay, so we have the fetal capillary. So that will, we call it as the tertiary villus. This is the next stage. Okay, so in the development of placenta, first is the decidual reaction or formation of the decidua basalis. Then second is formation of chorion with the further formation of chorion frondosum and chorionic levae. So chorion frondosum is important for us for the formation of the placenta. Third stage is the development of the villi. Okay, chorionic villi. So this chorion villi will further, they all will ramify like this. Okay, so this we call it as the truncus, like the stem. Then the branches we call it as ramus chori. And more further branching, we call it as the ramuli chori. And they will be attached to this cytotrophoblast shell, that is separating the decidua, basalis from the syncytial trophoblast. Okay. So this actually, this shell, no, the cytotrophoblastic shell will later on form what we call it as the Nitterbugs membrane. And this Nitterbugs, okay, so Nitterbugs membrane, it forms the Nitterbugs membrane. So this formation is very important because with the formation of Nitterbugs membrane, it separates, okay, the maternal and the fetal site. So it serves as like, barrier there so that it prevents the antigen antibody, because see, this entirely two different sources, two different individuals, the placenta has been formed, maternal and fetal. They are entirely two different parts, right? Two different individuals there. So there should not be, when there is a mixing of, when the blood, maternal blood and the fetal blood, when the exchange is happening, okay, they'll be mixing the blood. So this will, they can initiate an antigen antibody reaction, and this is what will prevent that, okay? So these villi which gets attached here, we call them as the anchoring villi. Okay, so this portion towards the decidua, that portion we call it as the decidua basalis part, no? There is with the basal plate, and this side will be the chorion plate. Okay. Now the maternal blood vessels, they will, so this is what was Nitterbugs layer, what I told you. So this is the cytotrophoblast cell. And outside that, that syncytiotropoblast will form the Nitterbugs layer. I think I said cyto, it is syncytiotropoblast. So here from the decidua, what happens now? The maternal blood vessels, okay, the blood will be poured within these intervillous spaces. And between these intervillous spaces will be the tertiary villi and containing the capillaries. So that the exchange will be happening there. Okay. So this is how it forms. Okay. So with further development, the lobulation. So lobulation, when we say here now, so this is the basal, that is the chorion plate. Okay. So this is the villi which will projecting. Now these are the tertiary villi. This is the trunk. That is the truncus cori, ramillae cori, ramus cori, and ramillae. Okay, cori. These are the further branching. And this is the decidua part. So here the decidua, that is the decidua basalis part, that is, okay. So it will project within this chorion frondosome part, okay, it forms a groove, it projects here, which forms the endometrial septum here, what, okay, between these intervillous spaces here. So this leads to the formation of lobulation of placenta, okay. So the placenta is divided into many lobules. So this is how the fetal surface will see. It is okay. It will be glistening and shiny with the membrane. This is the amnion, we say. Whereas this surface here, you can see many lobules. So normally there will be about 15 to 20 cotyledons. These lobules are also called as cotyledons. So it will have that many, okay. And at full term, the placenta will measure about 15 to 30 centimeters in length. Thickness in the central part will be about 3 centimeters. It weighs about 50 grams. Okay, and the proportional of weight between placenta and the fetus, which includes in the first month, it is about, the placenta weighs more compared to the fetus. It is 6:1. Fourth month, both will be equal. Placenta as well as the fetus will be same, 1:1. And at birth, it will be reversed, 1:7. Next is placental barrier. Okay, so placental barrier is very important. So here, what are the constituents of this placental barrier? Now, the placental barrier in the early pregnancy and in the later pregnancy, it differs. Okay, so in the early pregnancy, what happens? This placental barrier is formed by, now here if you see, this will be the syncytiotrophoblast, the cytotrophoblast, the basement membrane of the cytotrophoblast, the extraembryonic mesoderm, These are the blood vessels. Okay, this is what picture is this is if we take the villus, okay, and when we take a transverse section, this is how will it appear. So these are the fetal blood vessels in the core of the villus, right? Okay, so the endothelium lining of this fetal capillary. So all this, there are about 5 layers during the early pregnancy, but later on after 6th, 7th month, it changes, okay? So syncytial trophoblast, cytotrophoblast, basement membrane, extraembryonic mesoderm, and endothelium of the fetal capillaries. Then in the later pregnancy, okay, pregnancy, what happens? There is this fetal, syncytial trophoblast, it becomes very thin, okay? And here if you see, the endothelium lining of the fetal capillaries will be almost in contact with the syncytial trophoblast. So only the syncytial trophoblast and endothelial cells of the fetal capillaries, they form the placental barrier. Now, why it becomes thin is, okay, here the cytotrophoblast will disappear, okay, and the basement membrane also disappears. So this becomes, the lining becomes thin, okay. So next is classification of the placenta. Classification of the placenta. Placenta is classified as epitheliochorial, synepitheliochorial, and endotheliocorial, hemochorial. So basically it is the part of the fetus coming in contact with the maternal part. Now epitheliochorial, when we say, it is the fetal part coming in contact with the epithelium. Okay, so there the maternal part is the uterine epithelium, and fetal part is the chorion. So they just come in contact. So that is called as the epitheliochorial. Okay. Then we have synepitheliochorial. So synepitheliochorial, here what is happening? Both the epithelium, okay, they come in contact. Means it gets mingled. Okay. So this is synepitheliochorial. Then we have endotheliocorial. Endotheliocorial, here what happens? The endothelium of the blood vessel, if you see here, okay, the endothelium of the blood vessel comes in contact with the chorion. Then we have hemochorial, where the blood, okay, maternal side, the maternal blood itself comes in contact with the chorion. So this is called hemochorial. Then we have also endothelial, that is blood of the mother, that is the maternal side, comes in contact with the endothelium of the fetal blood vessels. Okay, endotheliocorial, here we say this is the endothelium of the maternal blood vessel coming in contact with the chorion. Okay, so that is the thing. Then endoepitheliochorial is the endothelium of the maternal blood vessel will come in contact with the endothelium of the fetal blood vessel. Okay, so endothelial we call that. So those are the different phylogenetic classification of the placenta. Then based on the attachment of the umbilical cord, we have battledore placenta, where the umbilical cord is attached to the margin. Okay, velamentous placenta, here what happens, the umbilical cord, if you see here, before it gets attached, usually it is attached almost near the central portion, okay, the umbilical cord. But here, just before it reaches the placenta, it will divide, okay, and through a thin membrane, and through its branching, it gets attached, okay. This is the amnion. So through the margin, it gets attached to the surface of the placenta. So this we call it as the velamentous. Then we have Purkinje placenta. So here the umbilical cord will reach up to the placenta, and then it will divide into many branches. So that is called as the Purkinje placenta. Then according to the site of implantation. Okay. So here when the placenta is in the lower part, okay, this is low-lying placenta. If it covers the internal os, we call it as this is the internal os, we call it as the placenta previa. When slightly it is encroaching, okay. Usually this what happens with the growth of the fetus, it gets shifted. But here it is completely covering the opening. So this is called as the total placenta previa. Now, what do you think is the danger here? Placenta. So when the cervix dilates during the normal pacturation, so the first presenting part will be, instead of the fetus, it will be the placenta. See, placenta will detach only after from the uterine wall, only after the delivery of the fetus. Okay, the fetus has to be delivered first, because till then the fetus will be requiring oxygenation, will be okay, from the maternal side. So it needs to. So here what happens in this case, the placenta will detach. So that we call it as the abruptio placenta. Because of that, it can lead to fetal death and maternal hemorrhage also, even though it endangers the mother's life. Then according to the penetration of the placenta, okay. So accreta is where it is just confined to the endometrium. Increta, endometrium plus myometrium, and percreta is the entire 3 layers. Okay, that is endometrium, myometrium, and perimetrium. So usually in these cases, we need to remove the entire uterus itself, okay, in percreta. Then according to the shape of the placenta, we have lobed placenta. We have placenta membrane where the placenta entire thing is covered by an extra membrane. Then we have circumvallate placenta. Okay, so all around the placenta, there will be thick membranous structure. Then we have placenta succenturata. Okay, so there is a main placenta. Along with that, there is one more small portion which is detached and separate. So what is the function of the placenta? So first thing is it exchanges, it is very essential for the exchange of gases, okay? So basically the supply of oxygen from the maternal blood to the fetal blood and removal of carbon dioxide from the fetal blood, okay? So that is the exchange of gases. So full-term fetus will take about 20 to 30 ml of oxygen, okay, per minute from the maternal blood. So that is by C. Per minute, about 20 to 30 ml of oxygen is taken. So even just a small cessation can be very fatal there. Then it helps in the transport of nutrition. Okay, so this exchange of gaseous and metabolic products. Okay, the oxygen is by simple diffusion, glucose. Okay, then sodium chloride, all the electrolytes, water, everything, okay, amino acids, they all take place by simple diffusion. Excretion of urea, uric acid, and creatinine, also simple diffusion. By active diffusion, we have the intake of amino acids, okay, here simple diffusion, fatty acids, okay, and amino acids by active diffusion. Calcium, inorganic phosphates, and ascorbic acid is by active diffusion. Fetal and maternal RBCs may cross the placenta barrier and transfer of maternal antibodies. Okay. Then it is also responsible for the transfer of maternal antibodies, forms of protective barrier, which is a storage organ for glucose. Okay, so excretion. So here, when it acts like a barrier, okay, so placental barrier here. So basically, why we have that earlier placental barrier and the later stage also we have the placental barrier. Basically, it acts as a barrier for many of the toxins and bacteria, okay. It also acts as a barrier for maternal hormones like ACTH, TSH, and all those things. Okay, so that is how it forms a protective barrier. Then it also produces certain hormones. Okay, so hormones, what it produces are, one is progesterone. Okay, so usually by the end of 4th month, so till then, what will be maintaining the pregnancy? It will be the corpus luteum of pregnancy. So it will be producing the hormone. But now the placenta will take up by the end of 4th month, okay, to produce progesterone, which needs to be which is needed for the maintenance of the pregnancy. Then it produces estrogens. Okay, so the estrogens, they promote the uterine growth and the development of the mammary gland. Okay, so it prepares the mammary gland for lactation soon after delivery. Then it also produces human chorionic gonadotropin, which has a similar effect like the luteinizing hormone. It also produces somatomamotropin, okay, which has an anti-insulin effect on the maternal blood. Okay, so because of that, what happens, since it has an anti-insulin effect, the levels of glucose and amino acids in the maternal blood, it will increase and it will enhance the utilization of this glucose by the fetus. So storage, it stores glycogen, calcium and iron in the early months of pregnancy, okay? So later on, that function is also taken up by the liver. Placenta is called as the homograft. So next is umbilical cord. Now, what do we mean by umbilical cord? So it is the part which will be attaching, okay? So it is a long cord-like structure, okay, by which the fetus is attached to the uterine wall, okay, to the placenta. So it connects the umbilicus, okay? So umbilicus, so it is from the umbilicus of the fetus to the center of the fetal surface of the placenta. So it is covered by a glistening. Okay, so it is covered by a glistening membrane, which we call it as the amniotic membrane. And at full term, one end of this cord is attached to the center of the anterior abdominal wall, that is towards the umbilicus. Okay. Now, if you see here, the umbilical cord is twisted and turned, isn't it? This is the natural twist. It's not like we twist it. It is a natural twist. So why it is like that? Because the umbilical vein here within the umbilical cord is larger compared to the or longer compared to the umbilical arteries. So to accommodate both of them, it becomes twisted and turned. Okay. So that is why we see like that. The umbilical vein, it is a very important question which is asked. So umbilical vein, what is long? Why it is twisted? So if you say the vessels to thing, so it is the umbilical vein which is longer and umbilical arteries are shorter. So this umbilical cord, okay, full term, it measures a length of about 50 to 55 centimeters, that is about 2 feet, and breadth about 1 to 2 centimeters. Okay, so initially, if you see here, it will be attached, okay, the connecting stalk here, it is attached to the roof of the amniotic cavity at one end of the trophoblast. Okay, so gradually with the development of the embryo, it becomes narrower and it moves towards the caudal end, okay, caudal end of the embryo. So later with the formation of the tail fold, with the formation of the tail, that is with the folding of the embryo, what happens? It gets shifted towards the umbilical opening, okay? So there it gets moved in the region of the umbilicus. So it will be connecting the embryo with the chorion. So as the placenta develops, the connecting stalk connects the fetus with the placenta. So that is why it is called. So what are the contents here? So the umbilical cord will contain mainly the embryonic connective tissue, which is like a gelatinous substance. Okay, that is known as the Wharton's jelly. So this Wharton's jelly will be protecting the umbilical blood vessels there. So other than that, there is also two umbilical arteries. You can see here, umbilical arteries are there. One umbilical vein. Okay, it's written placental, but call it as umbilical vein. Two umbilical arteries are there. Okay, and this is called, this is the Wharton's jelly. And in addition to Wharton's jelly, there is also remnant of allantois as well as vitellointestinal duct, because this is in relation of the umbilical opening where we had those two structures also, right? So remains of allantoic diverticulum and vitellointestinal duct is present. So what are the functions of the umbilical cord? So umbilical cord, it basically forms a passage for the structures, blood vessels mainly from the placenta, that is from the fetus to the placenta, that is the maternal placenta, okay? So these are the things we need to write about placenta. So what do we mean by placenta? the formation. That is, in the formation, we talk about the maternal and fetal. So the maternal part is the decidua basalis, and we have the fetal part is the chorion frondosum. Okay, so we need to talk about this. So first, frondosum. So first we talk about formation of the, that is, first thing will be the decidual reaction, leading to the formation of decidua basalis. Then we have formation of the chorion frondosum. Okay, chorion frondosum. And third, formation of the villi, different stages of the villi. Okay, so then the placenta forms. So these are the things, the placental ovulation occurs. Then classification based on attachment of the umbilicus, based on its site of implantation, okay, based on the degree of penetration. So we have the different classification of the placenta. So with this, we finish the class. And thank you for watching Auricle. For more content, you can follow the social media handles on Instagram, YouTube, Facebook, as well as Telegram. And if you haven't yet downloaded the app, you can download it on Google Play and App Store and start the journey with Auricle. Until then, next time.